Hi guys, my name is Jaz Gulati and welcome to this lecture on the fundamentals of occlusal appliance therapy. I've got this very treacherous task of going over splints with you, which we know is a super confusing subject, but I'm going to do my best in 1 hour or less to try and get some light bulb moments for you. And I'm so pleased you've joined us because by being here right now and watching this, you are supporting such a great cause by being part of the Complete Dental course. Obviously, supporting Akshaya Patra, which is just amazing. So thank you for being a superstar and joining us. And I hope that you'll gain a lot of value because I know that this has been very well priced and it's just wow. I mean, the caliber of speakers we've had. So I'm hoping to add to that bank of knowledge and I'm hoping you'll take a lot of things away from this lecture. Before we sort of delve into the deep, dark territory of splints, I just want to tell you a little bit about a story of me and my origins in dentistry. When I qualified, I did my DCT in hospital. But because I was so worried about de-skilling while I was in hospital, I maintained my hand in Saturdays in this practice, which is very close to where I lived in West London. And this practice was very interesting for me because when I'd go there on my Saturdays, I'd treat my patients and I'd be reading the notes. And the dentist that used to work there before me was the person who owned the clinic, and he was the prosthodontist. Now, he's actually a very well-known prosthodontist. But when I was reading his notes, for every patient, I'd see a heading. And that heading would say, wear facets. And he'd name, 5 or 6 different teeth, or several teeth, or just a few teeth that had some wear facets. Now, the trouble is, he must have been making this up, because when I'd look at the patient's mouth, I couldn't see them. I just couldn't see these wear facets for the life of me. So that got me really thinking, am I missing something here? And of course the answer is yes, I just didn't know what I was looking for. Because back then, I would have looked at this and thought this is all normal. And I may not have identified that if you look closely enough, premolars do not have a dent in them on the facial surface by the occlusal surface. They don't have that piece of anatomy. So there's something different about it. So that's what you call a wear facet. And I just wasn't seeing them before. I just couldn't spot them. And that's because my eyes hadn't been open to them. So that's an important part of my journey because I started to think about wear facets. I started to look out for them a bit more. So thank you to that prosthodontist who inspired me without even knowing. The aims of this one is basically let's diagnose signs and symptoms of power function. Such a huge thing, right? Like how many of our patients are grinding and clenching and destroying their teeth and then hurting their muscles? Loads of them. So I'm hoping that this will be useful in that regards. I'm also going to touch on the evidence base for bruxism and TMD. And just in a nutshell, it's poor. Like the research is poor. I'm not saying that splints are poor or the management of bruxism that we have is poor. It's that the quality of research is poor. The studies haven't been done. We need a lot of sleep studies because a lot of the grinding is done in our sleep. And there hasn't been enough funding in the research for that to happen. But I will help you to appreciate some of the different splints in the management of parafunction. Now, why I say management and not control is because no matter which camp you come from, you have to accept that actually we can't switch bruxism off. We sometimes can, I'll touch on that in this lecture, but it's difficult. So the role of appliances is not like you give someone a splint and they'll stop their bruxism. That's not the case. You're just transferring that bruxism onto the splint. The splint never stops them from bruxing. So just get that in your head. And in this limited time that I have with you, I just want you to remember that the purpose of an educator is to replace an empty mind with an open one. There is no way I can teach you everything about splints in 1 hour. So if that's what you're expecting, it's not going to happen, okay? Instead, I want to hopefully inspire you to see the world in a different way, to appreciate which patients may benefit from a soft splint, which might need something a little bit heavier duty, what's out there, why is it out there, and how we can make it work in our practice. So that's kind of what I want to cover. And another reason why I'm into this field of occlusion and bruxism and appliances is because I myself I'm a huge bruxist, okay? And I rely very heavily on my splint. So if I go a couple of days without my splint, I start to get myofascial symptoms. So I start to get ache in my masseter. I just feel grumpy and I'm off and I'm not myself. And it's funny because I actually gave myself Invisalign, and in doing so, and I knew what I was doing as I was doing it. I have qualifications in orthodontics, so I lost my anterior guidance. And I took that risk. And for me, being a bruxist, that wreaked havoc on my muscles. So I rely on this appliance and I don't want to get any more orthodontics and stuff. So that's maybe a debate for another day over a drink. no one really cares about this, right? This is not important. What it's about is this slide right here. Like, there are so many mentors I have that I identify as people who've helped me along my journey, people who've taught me their school of thought, taught me their philosophy of occlusion. And so I owe all of my knowledge to these guys, including the Dawson Academy, from these fantastic educators you see. So it doesn't matter where I've come from, but it matters about who I've affiliated with and whose brains I've picked. And my wife will tell you that, you know what? Over the last 8 years or so, I've spent a lot of money on occlusion courses. Hands up if you feel that way as well. And the problem was, even after all that money, all that time I spent on occlusion courses, Occlusal Appliances still gave me a headache. And I know it gives so many of you headaches as well. Like, this is a challenging field. Like, you thought occlusion was challenging, but the problem with these occlusion courses is that they don't really cover it in depth, and it might just like 1 hour at the end of the day, or one patient, or one type of appliance. Now, if I told you there was just one type of composite or one type of ceramic to rule them all, you wouldn't believe me. So trust me on this, there's no one magic splint. It needs to be led by diagnosis. So eventually, when I was really confused, like many of you, all of my patients just got a soft splint, right? That's what we just gave to everyone because it's cheap and easy and doesn't take much adjustment or knowledge or skill. And that's what we had, basically. So I'm hoping to open your eyes to other ways. And so essentially the journey of frustration begins at dental school, because we're taught by the restorative department at dental school that the Michigan splint, and if you don't know what that is, don't worry, I'm going to go over it. The Michigan splint is the most amazing appliance, and everyone should be just given one of those, and all their TMD and all their problems will go away. But at the same time at dental school, on the oral surgery department and oral medicine, they were just giving everyone soft splints. There was no mention of a Michigan splint anywhere. So that was really confusing. And then you go on courses, and it just barely scratched the surface. And then on my clinical experiences, I'd give these splints to patients, and they didn't wear them, firstly. If they did wear them, they'd chew through them, or they sometimes made their symptoms worse. So I didn't understand what was going on. And of course, then I started to delve into the literature, because as I was a DCT in restorative, I was being trained to think critically about the evidence. So I started to read the evidence, and I thought, wow, what an absolute pile of crap. Because when you read the evidence, you'll see that actually so much variability in the different studies, and you can prove that any appliance is better than any other appliance. Just you can find that literature for it. So the quality of evidence, not because the researchers weren't good enough, it's because of the funding, because of the methods, because of the low N numbers that are used. There's just not enough evidence to draw really good conclusions, which doesn't mean that splints don't work. It's just got poor evidence base. So I'm hoping that some of the learning points I'll cover is the when to use an appliance, the why to use an appliance, but something that might be beyond the scope of the next 50 minutes or so is the how. How is a whole, teaching you step by step. So that's probably a little bit difficult. I'll tackle a little bit of the what. The who in terms of patient selection might be a bit difficult. The which is a bit difficult. So you've got to have realistic expectations of what we can achieve, but I'll make it as impactful as possible. So guys, why does this matter? Well, what's the number one threat to our restorations now? In 2021, what's the number one threat to our restorations? Is it secondary caries? What's the number one cause of cracks in teeth? Is it that people are eating too many nuts? That's what my patients tell me when I diagnose wear and cracks. They say, oh yeah, doctor, I eat a lot of nuts. Okay. And then what's the number one cause of chipping? All right. So parafunction, I'm hoping you guessed that, is a huge problem. Okay. So this is why we should have some knowledge on etiology and also the management up our sleeve. And maybe you felt this way as well, that during this pandemic, you're seeing a lot more patients with cracks. Now, I don't know if that's just because they're presenting to us now or it just feels that way, but maybe they've just always had these cracks and you're just noticing them more now. And what causes these cracks and wear sets and stuff? It's bruxism. But we need to kind of change the way that we think about the word bruxism, because we've been taught that bruxism is a really bad thing, it's a dirty thing. But we actually need to change our mindset, okay? Think of bruxism as two different things, okay? There's normobruxism, because face it, every patient you look at, you'll be able to find a wear set, right? So you can't then automatically counsel all your patients bruxism. It's just not practical. Then there's the pathobruxism. These are the ones who are bruxing and then now they're experiencing the harmful effects of bruxing. be it a TMD, which we'll cover shortly, be it muscle pain, be it tooth fracture, vertical root fractures, significant wear. So understand that bruxism actually is a normal behavior. And what they think is that actually by bruxing, by moving a mandible around, you're opening the airway, you're making more patent, you're lubricating the mouth. And so therefore, it's argued that bruxism has a function, and it's not a bad thing, it's just a behavior. When it becomes bad is when it's excessive or at excessive force, or whichever point you start to get all the harmful effects of bruxism. And I mean, the first thing I want to ask you is, should your teeth touch while you are sleeping? Like, why don't we discuss this at dental school, right? So these are not just philosophical questions, these are important questions, okay? Should your teeth be touching while you are asleep, right? Well, not a lot, apparently, and according to some of the research, some of which backed by sleep studies, most of it which is not, is approximately 3 minutes a night, and not with much force. Okay, so the average person may just touch their teeth together 3 minutes in an 8-hour period of sleep, for example. But then some patients, okay, who are pathobruxis, they might be grinding and clenching for 11 minutes, and the contractions that they're able to make are much higher. So you can see a difference between those patients that we see who have the worst effects of bruxism, and then the average patient who's got maybe a little bit of wear and they're not suffering, they're not breaking their restorations left, right, and center. So there is a difference between these two populations. So how relevant is the occlusion in all this? Well, I just want to pitch to you another question, which is, how many minutes a day do our teeth touch together? So during the day, while you're at work, while with your family, while you're going about your normal day-to-day life, how many minutes a day do your teeth actually touch? Okay, so some of the studies have variations, but the answer is not very much. Let's call it 18 to 20 minutes, right? And it's actually mostly during swallowing, because when we're eating, there's a bolus in the way. So our teeth are not touching, if they are, with not much significant force. Because if there was a lot of force, this is what it would feel like. It's like when you walk up the step, and then you think there's another step, but there isn't, and you sort of like thud, okay? If your teeth kept hitting each other while you're eating, I promise you, it would feel really weird. And maybe it's happened to you before, where you've sort of found a seed or something in your food and you've sort of jolted. So our teeth don't typically touch while we're chewing. It's mostly while we're swallowing. So if we're only keeping our teeth together, or we should be only keeping our teeth together for about 18 to 20 minutes a day, why are we making such a deal of the occlusion? That's like 1.5% of the whole day, right? So have a look at Lee's occlusion here, okay? And hopefully we can agree that Lee is a pathobruxis, okay? At age 52, he's done this to his teeth. So hopefully we can see that, yes, there will be erosion as part of it. There is definitely bruxism part of it. And because the bruxism is now causing significant wear and destruction, we can now classify this as pathobruxism. But and I just want to mention, by the way, the reason you see DJ Khaled on the screen here is because this is a major key. So anytime you see DJ Khaled, it means that I'm raising something that's very, very important, and you should take note, okay? There's a difference between occlusion and occluding. So Barry Glassman was the first person to teach me this. And so it makes sense, because if our teeth are only touching for a small amount of time per day, then why are we putting so much emphasis on the occlusion? So the lesson here is basically occlusion, yeah, it's important, okay, we know that, but perhaps it is not as important as the occluding. So how many minutes a day the patient is touching their teeth together, at what force, and this is what causes the damage, not what the occlusion looks like. Now, of course, if you have a favorable occlusion and you're grinding in a favorable occlusion, maybe you're grinding in a beautiful way. But if you have a messed up occlusion and then you're grinding on a messed up occlusion, maybe that messed up occlusion is amplifying the negative effects of the bruxism. But the problem itself is the bruxism. If the bruxism wasn't happening, then maybe the harmful effects wouldn't happen as much. So it's just some food for thought for you. So we know that Lee produces destructive forces. Okay, so I'm going to pitch it to you. What options do we have to manage this situation? Okay, well, if you ask me, there are about 3 options which we might commonly encounter, okay? Number 1 is, okay, let's do some orthodontics. Maybe you want to intrude that upper left one, fix the cant a little bit, and you know what? Let's do a full mouth rehabilitation, because there's quite a bit of exposed dentine, missing teeth, and we need to raise the occlusal vertical dimension. You know that when we raise the occlusal vertical dimension, we're almost committing to at least a full arch of treatment. So in this case, hey, why don't we charge him 50K and do a full mouth rehab, and maybe after that, to protect him from the forces that cause his teeth to be like this, let's give him a splint afterwards. Okay? How many patients do you have in practice who are ready to go with that option right now? Not many. Do nothing, which is the easy option. You know what? You're not in pain, right? There's no active caries. Okay, fantastic. We'll see you in 6 months. Or maybe, just maybe, you can do something to stop things getting worse. Okay? How do we decide what we're going to do? Well, we need to consider, how can a splint help Lee? A splint can protect the teeth. It can test the compliance to, hey, can this patient actually tolerate and wear a splint? It's reversible treatment, which is good. We want reversible in this medical legal world. We don't want to be doing anything crazy. Reversible treatments are safe. It can be diagnostic. For example, if he was in pain, then can we get rid of the pain using appliance? And that can give us a lot of information. What a splint will not do is make his teeth look beautiful. It will not make sure that he wears it every night, because that's down to his compliance. And it's unlikely to make the situation worse. Yes, we need to consider bite changes, and yes, an airway diagnosis is important, slightly beyond the realms of this lecture. But only Lee can decide what his, depending on what his goal is. So if Lee says to us, I want to be able to smile again. I've got my son's wedding coming up, and I want to be able to smile, and I hate the look of my teeth, okay? Does this patient need a splint? No, this patient needs that rehab I was telling you about, right? Yes, there are less fancy ways of doing it, but essentially we need to do some restorative dentistry. If, however, the patient says, you know what, I just want my jaw to stop hurting, okay? If the main goal is pain, do you really want to do a full mouth rehab? Surely it makes sense to give a splint first to make sure we can get him out of pain before we go for something that's expensive and complicated. So yes, if he wants things to stop hurting, an appliance is justified. But if he just says, you know what, I have no pain, I'm fine, I don't care what my teeth look like, but I am concerned for the future, and I'm not ready for treatment yet, maybe this is the time where you maybe just plan a few restorations, protect the fragile teeth, and you give a protective splint. So that's how I want you to think about it, right? It depends on the patient's goal, whether you do restorative dentistry or you just give an appliance. That has something to do with it as well. And sometimes these patients don't appreciate the value of a tooth, right? They're like, yeah, but I don't want to wear a splint. But then you have to consider, what's the fee for an implant, and which direction are they heading in? Are their forces so destructive that they're likely to lose more teeth in the future? So we need to make it very clear to the patients. We need to reduce the failures, because how much do failures cost a practice? And one of the biggest causes of failure in the modern world is fractures and broken cusps. Yes, the problem is compounded by these large MOD amalgams placed 30, 40 years ago. But a lot of these patients will even destroy virgin teeth with vertical root fractures. You might have seen this already. So there is sort of a case for helping these patients who are higher biomechanical risk or higher functional risk. And this is what I mean by functional risk, okay? This is Angela. She's 72, and she has destroyed her previous appliances. Like, anytime you give her a splint, she will absolutely destroy it in a matter of weeks. So there's a saying that Michael Melkers taught me, which is past is prologue, okay? To make that tangible for you, whatever has happened in the past will happen again in the future. So if they destroy their dentistry, like look at this bridge, okay? It's absolutely destroyed, okay? It's actually all the margins are opening up, the crowns, the bridge is now poorly seated because there's so many root fractures inside there. There's also, look at Angela's muscles, look at her master muscles, they are huge, okay? So Angela's a golfer, and when she plays golf, she properly clenches her teeth, and when she bulges her masters, it scares me a little bit, I'm being honest with you. And look at the severe wear of her lower incisors. Now I know what you're thinking. You're thinking, Jaz, calm down, okay? Angela's 72, leave her alone, okay? What if I told you that, yes, Angela might be 72, but the bridge is just 6 years old, okay? That is a lot of destruction, okay? She's perforated a metal ceramic bridge. You can see a perforation on the upper left one. So this is huge. So we know that Angela is very high functional risk. So we need to do a biomechanical risk assessment. We need to notice these often silent but significant findings like exposed metal, chipped ceramic, significant wear facets all around. And this patient might come to you, this is Yun, he's 42, and you see, what do you see? Well, you see signs of wear, right? So what do you want to ask Yun? Well, you're probably going to ask him, do you grind your teeth? Right? That might be a question that you might ask someone, okay? Now, based on your experience so far, what do you think Yun is going to say? No, right? Now, we can see that he has been, right? Unless a dentist previously went and drilled his teeth in that exact specific fashion, or he's been getting a nail filer and going at his teeth for a while. We know, you and I know that this is a parafunction. The patient doesn't know that, yeah? So the correct question to ask is not, do you grind your teeth? The correct question to ask is, are you aware that you grind your teeth? And of course, if this time they say no, it means that they're just not aware yet. So it's a clever little trick, and you should use it because it's a better way to communicate, right? So the other thing not to do is be judgmental. Like you shouldn't say to the patient, you are grinding your teeth, okay? Because they'll get very defensive. It's something that they just get very defensive about. So the better question is, did you know that you had the signs of teeth grinding? And then be like, oh, I do, because they can't argue with that. They can't argue with what you're seeing. So if you just inform them that, hey, did you know that you have the signs of teeth grinding? This is a better way to communicate. So generally the signs of parafunction are wear facets, large muscles. They may have tender muscles, tender joints, joint noises, cracked teeth. Okay, mandibular tori has weak association, but it does as well. Increased mobility. Like I have helped some patients before, whereby they just got grade 1 mobile teeth, like pretty much everywhere, right? And they got really strong muscles, and they're really going at it at night with their bruxism. And after giving them appliance, 6 months later, their teeth like are rock solid. They firm up. So it's amazing to be able to do that. And so sometimes this mobility is not perio disease. It's actually increased physiological mobility because of the bruxism. Abfraction is debatable. Sensitivity, which I'll touch on. Headaches is a big one. We see this a lot. And there are, of course, soft tissue signs that we can identify as well. So wear facets, the easy one, like I said. I say easy, but I struggled at the beginning of my career to be able to notice these as wear facets. And here you might be thinking, Jaz, okay, you've lost the plot now. You're overdiagnosing. There are no wear facets here. But look closely at that upper left molar or that lateral incisor. There's no textbook in the world that has an upper left molar with this shiny sort of elliptical area, right? That's a wear facet. Fair enough, we might not need to do anything about this patient, but it's good to record and good to know that, okay, there are some early signs here. Let's keep an eye on it. Maybe this is just normobruxism and not pathobruxism. Then you can see a bit more destruction. You can see this pin-retained composite. Anytime you ever see a pin-retained composite, it means the practitioner tried 4 or 5 times, and finally it was the pin that helped the composite. So that's what that usually means. And we can see that there's progressive destruction. So this is something that you really need to look at in a different way and think that, okay, what the hell happened here? Because these teeth are flat, they are destroyed. And now we see something that's not so destroyed. You see very mild signs of wear facets, okay? So this is not that significant, okay? And we might not need to intervene. But again, it's just something that we can note. So in that diagnosis chart, in our notes, we can just make a note of wear facets, okay? When we have virgin teeth that get root fractured all the way along, that is significant. You have to generate a lot of force to do that. And then to figure out if the parafunction is active or not, it can be quite tricky. But there are a few signs that we can look at to figure out if parafunction is active or not. So first one is tongue scalloping. Okay, now you'll see my dirty tongue as well there because I am a massive bruxist. I've told you that already. And all these patients have some degree of tongue scalloping. And sometimes when patients stick their tongue out all the way, you don't see it. You almost have to sort of get them to curl it back a little bit before you can see the tongue scalloping. You also see this cheek ridging or linea alba. And sometimes it can be really marked, and this is an ulcerated cheek. And other times, this is one of my most active parafunctional patients, you can see the gross cheek destruction. And you might see lots of cracks that are just getting, not always around these big fillings. They're just happening on teeth with just small restorations as well. And sometimes you see some exostoses. Now, literature says there's a very weak association with bruxism. Sometimes it's genetic. People in the Asian population seem to have lots of tori as well. And sensitive teeth is an interesting one. I remember placing these bridges when I was in hospital, and the patient came back in pain, right? And the reason why this patient came back in pain is because I hadn't done a thorough check of the occlusion. Again, that word occlusion again. But it's not the occlusion that caused the issue, it's that the patient was grinding at nighttime, and I didn't get rid of the excursive guidance on that pontic. And now that was levering that premolar, which was used as a abutment, and therefore the patient was getting pain and sensitivity from the premolar. When I adjusted it, when I removed a bit of ceramic or a little bit of enameloplasty of the opposing tooth, the pain settled. So that's an example of how parafunction can cause sensitive teeth. And so one of the things that I do a lot of as well is I color in occlusal appliances. so that patients can sort of see for themselves. So once they're sort of committed to an occlusal appliance, we want to know, is the parafunction active? Now, because my case selection is pretty good, and I try not to over-prescribe appliances, I try and prescribe appliances to people who are actively parafunctioning, and there's a real tangible benefit for them to be had. And they'll be amazed when they come back and they see all these wear facets. And that's when the penny drops for these patients. That's when they see that, whoa, I was doing that and I could have done that to my teeth. And then suddenly you find that the compliance with these splints is much better as well. So it's all about co-diagnosis, showing the patient that what we can see. That happens through photos, but that also happens through splints and when we color them in. So what will be better than a splint? So I've shown you a few splints already, but obviously to stop the bruxism habit is better than having a splint. So the question is, how do we actually do that, right? Like if there was a magic pill to stop bruxism, you'd be a billionaire. You'd probably make more money than the person who invented Viagra, right? Like this is such a wanted pill to have, but there's no such thing, unfortunately. So we have to look at, what do we know about the etiology of parafunction? Well, there's been a bit of a paradigm shift, because you might have heard this at dental school maybe, or from textbooks. Maybe you've read this in textbook, that sometimes having an interference in your bite will cause or initiate bruxism. Just think about that. I was taught this at dental school by some of my tutors, that actually if you equilibrate the patient, if you make their MIP equal to their centric relation, that will help their bruxism and their TMD will be cured, right? You might have heard this, but actually this is not the case at all, because think about it, about 90 to 97% of us have a slide, right? We normally have our bite which is not within the arc of centric relation. Therefore, we all have a slide, and therefore, is that what's causing all our bruxism? Very unlikely, to be honest with you. So now we accept that actually it's nothing peripheral, i.e. nothing to do with the shape of the teeth or interference that causes our bruxism, but it's actually something inside here, something in our head. It's like a switch, and we can't switch it off. Or we might be able to if we figure out what's causing that switch to be on, but it's probably nothing to do with the shape of the teeth. So the evidence is heading away from a morphological cause of parafunction, and there's really a lack of evidence to prove occlusal factors are an etiological fracture. And Manfredini, who's written a PhD on this entire subject and is probably one of the well-referenced researchers in the area of parafunction and bruxism and TMD. However, the great Peter Dawson, whom I had so much respect for, rest in peace, he said something really good. He said, total reliance on evidence-based literature is a worthless argument if the literature does not follow the rules for evidence-based research. Let's listen to that again. Reliance on evidence-based literature is a worthless argument if the literature does not follow the rules for evidence-based research. Okay, so what this basically means is that the quality of the evidence itself is really poor. So can we really trust it? And the lack of evidence doesn't necessarily mean a lack of effect. But what the evidence does show between a 5-year period in 2000 and 2005 in this review is that about 10% of the literature suggests that occlusion, or a certain type of malocclusion, or interference, for example, might be the cause of bruxism. About 20% suggests that it's something psychological, stress, something that's causing anxiety that might initiate bruxism. And interestingly, 70% of the evidence suggests that it could be something pathophysiological, which means things like obstructive sleep apnea that cause it, or other diseases that cause it. So let's look at respiratory disturbances, anything that causes you to get less air in. And then the body's protective mechanism, so bruxism is like protection. It gets you to move your mandible and the muscles go crazy to allow your airway to become patent. That's the theory. So because it's the actual obstructive sleep apnea that causes these sleep arousals, gets these micro arousals in your sleep. And it's actually during the times of micro arousal that bruxism actually happens. Anything that messes with the central neurotransmitter system, so certain painkillers, for example, certain antidepressants will cause bruxism because it changes how the central neurotransmitters are working. Gastric esophageal reflux disease has been implicated. And so the theory behind that one is someone who's got reflux at nighttime and you've got acidic environment in the mouth. By bruxing, you're producing more saliva. And that's seen to be like a gastroprotective sort of reflex, if you like. And anything that, things like alcohol, caffeine, these are also implicated in causing bruxism. Then in the second column, psychosocial, there's stress, anxiety, emotional disturbance, which actually that's the one that we were taught at dental school. That's the most common one to blame. That's probably the easiest one to say to patients, "Ooh, are you stressed?" So that's something to always consider. And the whole occlusal thing where MIP is not equal to CRCP causing it, yeah, I don't think so. And there's really a lack of evidence for it. But, it's out there to be debated because the research is just not good enough. So why does this matter? So the reason this all matters is that bruxism is a sign of something. Let me say that again. Bruxism is a sign of something. It's not a disorder, okay? It is a behavior. Let me make that tangible for you. Imagine your child has a fever, okay? How pissed off would you be if you rang the doctor and the doctor, after running all these tests, said to you, "Hey, I've got a diagnosis. My diagnosis is fever," right? So you'd be totally like, what the hell is this doctor saying? I know he's got a fever. What's causing the fever, right? There's an infection somewhere. There's something going on, right? There's some inflammatory marker, whatever, right? Is causing the fever. In the same way, bruxism is like almost like a sign of something else. So bruxism itself is a behavior. What is causing the bruxism? Is it the fact that this patient has a mild sleep apnea? Is it that they've got severe anxiety? Is it an occlusal issue which may or may not be the cause? That kind of thing, right? So bruxism is something that's like a fever. So therefore, we need to treat the root cause. Just like with someone with a fever, you might treat the infection and they get better, or the body heals itself. We need to get rid of the infection, or we need to get rid of the cause of bruxism. But good luck trying to find that cause. So it's not easy, and it is multifactorial, we think. And what we got to start also looking at the person as a whole and start screening for airway issues, which is beyond the scope of this lecture. But I urge you all to consider it. In fact, if you email me at the end, S4S are doing a sort of 50% off an airway course for those who listen to my podcast. So I can help you out with that. But you essentially need to know this, okay? That splints will not stop bruxism, but they'll help us to manage the negative consequences of bruxism. And therefore, with bruxism, we get something called microtrauma. That's right, isn't it? And because patients grind and clench, they damage and overload the masticatory system, and therefore they get pain and problems. Now, do you think this is a reasonable model, right? This sounds like it makes a lot of sense, right? Unfortunately, it's far too simplistic. Okay, and in dentistry, you always want to start complicating things, and unfortunately, it's just not as simple, right? This is what we call the biomedical problem. So, i.e., you grind, something gets damaged, your muscle, your joint gets damaged, and therefore you get TMD. But actually, we know that damage doesn't correlate with pain. Like in some of these studies, imagine I pinpricked you, right? And I pinpricked 100 different people. Some of you would say, "Oh, yeah, that's a 2 out of 10 pain." Others would say that's an 8 out of 10 pain. And pain can vary. The experience of pain can vary by a factor of 4. Now, you've experienced this because you've given people ID block before, and it's the same hand, same technique, and some patients will say to you, "Wow, that was amazing. That was the best ID block ever. I didn't feel a thing. You're amazing. You're the best dentist ever." Whereas other people, you're literally hovering the needle above their mucosa and they're going, "Ah!" It's a difference, right? So that's why there's more to pain than just a mechanical damage. There's a patient's perception of the pain. So the accepted model of TMD is not the biomedical model. It's what we call the biopsychosocial model for TMD. So it's not just the occlusion, the TMJ, the muscle damage. It's also the patient's personality, what their coping strategy is like, what their perception of pain is like. So it's really, really complex. So bruxism does not equal TMD. And you know this already because you've got that big bloke, that big strong bloke with a huge jaw and the huge muscles who sees you every so often because they've got a broken crown, a broken tooth, and they're destroying everything. But guess what? They don't get any headaches. They don't have any jaw pain. They're just destroying their teeth. So it's more than just a physical condition. It's an emotional state. It's a perception of pain. It's also complicated by stress and depression and multiple conditions. So I just want to put that in there because I can't possibly cover a little bit of occlusal appliances without touching on TMD. Now we're going to refocus back on splints and just cover something very fundamental, right? So I've got DJ Khaled there because this is a major key alert, okay? People get very wound up about appliances and prescribing appliances. We need to boil it down as to reasons why you would give an occlusal appliance, okay? Just back to basics, why, okay? And in my book, this book inspired by my mentors, there are just 3 reasons three possible reasons why you give someone an appliance, or three goals, okay? Either you want to protect them, so you want to prevent further destruction, or something's hurting, their joint or their muscles hurting, and you want to stop the pain, or you're trying to figure something out. Even if it's just like, can this patient even be trusted to wear a splint? Compliance, or you're trying to get their muscles relaxed so that when it comes to recording your centric relation record, it'll be a bit more predictable. So those are the three things. And sometimes it's protection and pain, or pain and diagnosis, and a couple of things. Sometimes all three. But essentially, any reason to give a splint will be covered in these three main headings. So when it comes to splints, okay, if variety is the spice of life, then the topic of splints is very saucy, very spicy indeed, because literally there's hundreds of splints. There's just a few of the different splints out there. And every now and then a dentist comes along and names an appliance after themselves. So let's start with the basics, okay? If we're going to cover for the next bit about occlusal appliances, we've got a little background on occlusion and occluding. We've made a little background about how bruxism does not equal TMD necessarily. And now we're going to look at how it's difficult to control their bruxism because we can't figure out the root cause of it. We might manage it with appliances. So what are the different types of appliances? Well, two basic types, okay? There's one type called a directive appliance. And this is something where you give them an appliance and it's forcing them to bite in a specific way, i.e. it's directing their jaw in a specific place. This is a very niche group of appliances that as a GDP, you probably won't be prescribing. If you've ever given anyone a mandibular advancement splint or an anterior repositioning splint, this is a type of directive appliance because you're forcing the jaw to bite in a different way. So this is something that's, like I said, quite niche. A lot of people who limit their practice to treating TMD only, they might do that to help recapture the disc before they then do a phase 2 orthodontics and whatever. So just know that it's out there, but most of the splints that we prescribe are not directive. But just to show you how they work, they've got these indentations sometimes, and the teeth will only fit together in these indentations. So it brings the mandible forward usually. The one that you are more than likely going to be prescribing 99% of the time is a permissive splint. They don't guide the jaw in a specific place. The jaw and the muscles decide where they want to go themselves. So these are a couple of permissive splints, okay? The soft bite guard that you see with the lovely wear sets is a permissive splint. It's not forcing your jaw in any position. And the top one you see there is a anterior only segmental appliance. So it's just covering the front teeth. This is an anterior midpoint stop appliance, which I'm going to cover towards the end. And this patient is also wearing a lower Essex retainer. So these are both permissive because they're not forcing the jaw to bite in any place. The patient will just bite together and the muscles will figure out where to go. Then the next way you classify splints is partial coverage or full coverage. And in the UK, we have this whole dogma and thing about, don't ever prescribe partial appliances, especially the posterior ones that cause posterior occlusion. The jury's out there on what happens, but essentially anterior ones are a lot more common among GDPs for segmental appliances. But the most common one is a full coverage one, which is something that we get taught at dental school. So here is a posterior only appliance, okay? Lots of controversy around this subject, so I will not be covering that. And then most of the ones we do are the full coverage ones. And then finally, the third layer to classify splints is it hard? Is it soft? Or is it a bit of both? Either it's dual laminate, so it means it's hard on the outside and soft on the inside, right? So if you wanted a flowchart, by the way, to help you with this, if you just go to my website, protrusive.co.uk/flowchart, you can download this how to choose which type of appliance. This is just based on my experience, my philosophies, what I've been taught, and it's just helped me a lot to sort of simplify exactly when to do it. Now, understand that this is very much a basic guide, and like any guideline, you should deviate away. But I'm hoping this will help you to think of things in a different way. So if you just home in on one aspect of why you might prescribe a splint. So we said protection, we also said pain and diagnosis, right? I can't possibly cover all three in full depth, but I can give you a taster of the most common type of appliance or most common reason which you might give an appliance, right? So how many patients do you get coming in every week complaining of raging jaw ache and they're absolutely suffering, they got clicking, popping, severe headaches? I'm sure we all have a few, but it's not a daily occurrence, right? We also aren't doing complex OVD increasing dentistry every day unless you're a specialist. So diagnosis may be something else. Protection is something that a lot of patients might need or you might suggest because patients come in and you've diagnosed as bruxism and you're worried that they're going to destroy your delicate veneers or break your crowns or start breaking their own teeth. So I think protection is a good thing to cover in this lecture, right? So here are some appliances which you can give for protection. And really the crux of it is that any appliance will work for protection because essentially you're putting some plastic between the teeth. And if there is some plastic between the teeth, when they're grinding, they're destroying the plastic and not the teeth. So all these appliances will do. So why are there so many? Why don't we just give the same one, okay? Well, remember what dental school said about splints, right? They said Michigan splints are king, soft splints are useless, okay? And they said never make an anterior-only appliance. They are the work of the devil, right? They said that, right? They said that to me. They scared me big time when it came to the prescription of anterior-only appliances. And guess what? I do a lot of those now, okay? I'm very naughty, okay? But the thing that they always said that soft splints are useless, and this stems from that 1987 paper by Jeff Occlusal. It just had 10 patients. That's it, okay? And what they found is that muscle activity decreased in someone with a hard appliance, and it increased or stayed the same in people with a soft appliance. And interestingly, 6 of the 10 patients actually developed pain, so developed muscle symptoms or joint symptoms after the soft splint, right? So we all know this, yet it's still the most heavily prescribed appliance today. Okay, and it makes sense, right? Because when you give someone a hard appliance and you give them maybe a Michigan, so Michigan splint is like an upper hard appliance, and it's got canine guidance. It's basically got the ideal occlusion built into the appliance. So if you give someone an appliance with canine guidance, etc., which is like the one on the left over here, versus an appliance like a soft splint, which is, all the back teeth are rubbing everywhere, it kind of makes sense why they wouldn't work or they'd yield that result that they did in the Occlusal paper. But many patients actually tolerate these appliances well, okay? Not everyone gets pain. Some patients absolutely love this, okay? And is the most commonly prescribed appliance amongst any dentist in the whole wide world because it's cheap. However, why doesn't anyone quote this study by Wright, Anderson, and Schulte? Okay, no one ever quotes this, but it's something that actually counters against what Occlusal found. Okay, so this had 30 symptomatic patients, whereas the other study had 10 asymptomatic patients. So can you see already the variability in these studies and how difficult it is to draw good conclusions? Right? 10 people had soft splints. 10 people had palliative advice only, and 10 people had nothing. They were the control, right? And they found that people with the soft splint significantly got better compared to the palliative or no treatment, and that actually the soft splint, okay, you can adjust it in the occlusal surface. So the Occlusal paper said that actually, you give a soft splint and it's almost impossible. It actually says that word. It's almost impossible to equilibrate a soft splint. Whereas this paper suggested a protocol whereby you heat the splint. Okay, so that's me using a flame. You just melt the splint a little bit, and then you get the patient to bite together into that. And that forms some indentations. And then you grind away the indentations, right? And so when they bite together now, it's even on both sides. So this is something that I started to do. If you're going to do this, by the way, make sure you ask for a 4mm soft splint, not a 2mm one, 4mm one, because you want a bit of wiggle room for when you heat it. So I started to do this. So it's interesting how one paper said that is really rubbish, and the other paper, which had a different protocol, and they're both completely different papers, and it argues that splints can be useful and it helps patients with pain. But what about those patients that destroy the soft splint? Okay, we all have those patients that have destroyed the soft splint. They've perforated the soft splint. What do we do? Okay, well, how about we talk about a nutcracker, right? If you want to generate high forces in a nutcracker, you put the nut closest to the fulcrum. Okay, we all know that. Okay, this is a second-class lever. So why don't we convert this, to a third-class lever? So that's the TMJ on the left. That's the master muscle. Okay, and then if you move the food or the splint or restorative work, whatever, away from the muscle, so towards the front of the mouth, okay, this now becomes a third-class lever, and you can reduce the forces significantly, okay? Does this sound familiar, okay? This is anterior guidance, okay? So how about now, for that patient who is destroying that soft splint, why don't we reduce their forces or reduce how much force they can produce by giving them anterior guidance, okay? So how? we can give them anterior guidance with a Michigan or a Tanner splint. So remember, I said Michigan is an upper hard occlusal splint. Lower one is called a Tanner splint, okay? So the condyle is in a snug position in the articular eminence, so centric relation or stable condylar position. And when the patient bites together, they have equal intensity contacts. And then as soon as the patient grinds or excurses, then there'll be anterior guidance. So these appliances work in that manner. But the problem with these splints, remember we said protection, right? We're not giving this splint for pain or diagnosis. We're giving it for protection, okay? And what you'll find is that these splints are very time consuming and therefore expensive. Okay, so I wouldn't charge anything less than £900 for an appliance like this. Compliance can be poor. So in the famous Wassel study, they found that at some point only 31% of patients were actually wearing this. And the funny thing is, like we spend all this time to adjust this splint while the patient is laying down. Okay, so patient's laying down, we're adjusting it, and we get them to bite, grind, left, grind, right, while they're completely straight lying down. But when they sleep in funny positions, right? And we all know as we move our head and whatnot, our occlusion changes. So how does that factor into it? I don't know, but it's just a thought for you, okay? And what they found actually in this Wassel study is that whether they give a population of people a Michigan splint, well equilibrated, versus palliative advice only and conservative care, both groups got better, right? So the splint versus no splint and just advice only, both groups got better, okay? And like I said before, that doesn't mean that Michigan splints aren't good. I do prescribe them and they can work as well. But the point of this slide was that the compliance is not going to be great, especially for when you're giving it to someone for protection. So I used to give it and I used to feel really embarrassed when patients come back 6 months later and I ask them, oh, how's it going with your splint? And they'd be like, yeah, I'm kind of not wearing it. And I feel guilty because I've charged them so much money and spent so much time and the patient's not wearing it. You know, they have the best intentions as well, but it's not a nice splint to wear, especially if your Y is not big enough. So if you're giving it for protective reasons so that they don't break their teeth anymore, or they don't break your composite veneers or ceramic veneers anymore, then the patient may not wear it anymore because, you know, you might have had a splint yourself. It's not the most comfortable thing to wear in the world. So how about a splint then? Okay, so on this theme, okay, we try a soft splint. Yeah, they're gonna grind through it. They're gonna break it. Okay, you want to give them a Michigan, but maybe it's too expensive, or you don't think the patient will comply. Okay, what can you do? Well, how about a splint then that's been worn by millions of people all over the world? What I mean is the very humble Essex retainer, okay? So if you design these to be passive fitting, okay? Because what you don't want to do is give someone who's not had orthodontics a tight Essex retainer. They will not wear it, they'll hate you, okay? If you design it very generously blocked out with the undercuts, okay? And then it should just slip on and off very easily, okay? That is what we call a passive fitting retainer. So this passive fitting retainer could be the answer, right? Because it's hard, okay? They will hopefully not wear through it as quick as they did the soft bite guard. It should be much easier to wear because there's less occlusal vertical dimension opening compared to, let's say, a Michigan splint. And then you might get some wear sets over time, and this splint is 4 years old, and that's fine, that's good. But what if you start getting this? What if they then start chewing their retainer very quickly and they're destroying the retainer? So then you're back to square one, right? Then it's like a soft splint again, right? There's no real difference. They're just destroying it. So this asymptomatic patient who's got large muscles, high forces, and they want to wear a splint, but they're destroying their splint, what could you now do? Well, the answer, I think, is an anterior midpoint stop appliance, okay? Let me show you what this is, okay? It's essentially an Essex retainer with an anterior guidance, okay? So it's Essex retainer with anterior guidance. And some camps call this the B splint, okay? So this is my B splint, okay? This is the one I wear, and I told you already, I suffer from bruxism, and I need this for my pain. So essentially, it's a Essex retainer with a acrylic block at the front for anterior guidance. So this is what it might look like as well. This is a two-piece one. This is called a dual arch B splint. So as the patient grinds left and right, the back teeth can't touch, okay? Therefore, the patient cannot generate enough force, okay? So we're keeping it to anterior guidance, okay? So it's a hard appliance, okay? It's easy to wear. It does increase the OVD a bit, but it's not so bulky. And I find that patients tolerate this really well. And it's much cheaper because it's really so much easier to adjust, and it's plug and play, and it's really good. But before you go out there and start prescribing this appliance, there is a bit of a thought process. There is some diagnostics to be done. There, you have to sort of check how much of a slide they have, because sometimes what happens is that muscles, they relax so much that they can get an anterior open bite. So there is a little assessment to do, but just something to sort of give you some ideas, because you might have that patient who's a bruxist who has had orthodontics with you, and now they're chewing and destroying their Essex retainers. Then maybe that patient would be best served by having those Essex retainers with the anterior guidance built into it. That would actually make more sense than a Michigan splint, and it would make more sense than a soft splint because they've just had orthodontics, right? So there's lots of these accessory goals which you might have as well. So all in all, when we're giving splints, it is arts and crafts, okay? And we need to, A, consider their goal. Is it protective? Is it pain? Or is it diagnosis, okay? Consider how much force they produce, because if they've got really big muscles, they might actually chew through that soft bite guard very quickly. And then maybe they might destroy that Essex retainer, and they might not tolerate the Michigan splint, but I've always also met patients who actually have destroyed their Michigan because it usually cracks by the 7 region, right? Remember, the Michigan splint doesn't protect you so much when you're clenching. Your back teeth are still able to generate force. So maybe then an AMSA could be the solution, okay? Always have to consider how much they value the solution to the problem. So if they don't value the solution to their bruxism problem very much, they probably won't be giving you the money for a Michigan splint or giving you the time for a Michigan splint. So always sort of think what works best, what are they most likely to wear, so that you can protect your delicate restorations from these harmful forces of bruxism. So I hope you enjoyed that whistle-stop tour. I know I covered lots of different themes, and it's very difficult to keep it focused on just splints only because it's such a huge topic. I had to cover bruxism etiology. I had to cover the relationship between bruxism and TMD, and we went through one sort of indication, which is protection against bruxism, and I gave you a flavor of some things to consider when we're giving splints. If you have any questions, please do email me, and do check out my podcast, Protrusive Dental Podcast. It's listened to by dentists all over the world, and I also have a course on splints if you want to learn about the how, the why, the when not, that kind of stuff. But I hope you still found lots of values from this one. I'm happy to help you on Instagram as well. You can find me on @Jaz Gulati. Okay, thanks so much, and thank you for supporting charity. You are an absolute star.